Welcome back, Koei Academy CST students. Let's jump right into this explainer. If you're gearing up for the Certified Surgical Technologist exam, you are absolutely in the right place. Today, we're taking a deep dive into Lesson 3.2, Preoperative Documentation. Now, I know exactly what some of you are probably thinking. Documentation? Sounds like a bunch of boring paperwork, right? Well, actually, scratch that. I need you to flip that mindset right now. We aren't just learning how to fill out tedious forms today. We're embarking on a critical, life-saving mission. Every single piece of paper, every digital checkmark we're going to talk about is a literal shield protecting your patient in the operating room.
Seriously, I want you to sear this core philosophy into your memory for the exam. Documentation isn't paperwork. It is patient safety, period. Every single document you review before a case is a vital checkpoint. If just one of those documents is wrong or missing, you, the CST, have the absolute power and the duty to stop the line. You are the final line of defense, preventing catastrophic errors, like wrong patient or wrong site surgeries.
Okay, here's our roadmap for today. We're covering 1. How pre-op docs save lives. 2. Informed consent. Exam traps. 3. The universal protocol steps. 4. NPO rules and latex allergies. 5. H&P, labs, and DNRs. And 6. Special patients and a rapid review. Let's get to it. Section 1. Pre-op docs save lives. This is your non-negotiable required document set. Listen, these are your absolute non-negotiables. If a single one of these is missing, it's an immediate stop-the-line event. You simply do not proceed. On the CST exam, you're going to be tested on your ability to quickly recognize these documents and know exactly what to do when one is deficient. So, we've got the informed consent, which is the legal authorization that must be obtained by the surgeon. Then there's the history and physical, which details the patient's medical status and has some very strict timing rules. We also have allergy documentation, where all allergies, especially latex, have to be recorded. Then there's the NPO status, which dictates fasting times so we prevent dangerous pulmonary aspiration. And finally, advanced directives, like DNR orders, which require an explicit, clear discussion right there in the OR.
Moving on to Section 2, Informed Consent Exam Traps. This is arguably the most tested document on the whole CST exam.
The ultimate rule you've got to remember here is that the surgeon, not the CST, not the nurse, but the surgeon is legally responsible for explaining the procedure and obtaining that informed consent. Now, the exam loves, and I mean loves, testing exactly what invalidates this legal document. A consent is completely legally invalid if it's signed after premedication or sedation has been given. Why? Well, because the patient's decision-making capacity is officially impaired. It's also invalid if the procedure or operative site on the form doesn't perfectly match the schedule, or if it's unsigned, undated, or signed by someone unauthorized. Also, catch this. If a patient verbally withdraws their consent, even after they've already signed the paper, you must stop the case. And lastly, if the patient's condition has significantly changed, making the original disclosure inaccurate, that consent is completely dead. If any of these conditions are met, you stop the line.
Okay, let's test that knowledge right now. Put yourself in your OR shoes. Picture it. You're the scrub tech reviewing the chart. The consent form says left knee, but the schedule and the surgeon's preference card both say right knee. What do?
If you said, stop the setup immediately, then you are perfectly prepped for this exam question. You absolutely must notify the circulator and the surgeon. A brand new consent must be obtained. You never, ever cross out or alter an existing legal document. You don't just take a pen, scratch out left, and write right. No way. And let me be super clear about this. A verbal confirmation from the surgeon in the room saying, oh yeah, it's the right knee, don't worry about it, is absolutely not enough. You need a new, valid document. Section 3, the universal protocol steps. 3 steps and 0 shortcuts. These are mandated by the Joint Commission to prevent wrong site, wrong procedure, and wrong person surgeries. These 3 distinct steps have to happen in this exact sequence for every applicable case. Step 1 is the pre-procedure verification, out in the holding area, verifying we have the right patient, right procedure, and right site. Step 2 is the surgical site marking. And Step 3 is the timeout, which happens inside the OR immediately before the first incision, with all team members fully present and actively participating. Time for another quick exam knowledge check for you, this time regarding Step 2. Who exactly marks the surgical site, and when is it performed? The answer is the surgeon, the operating physician. They are the ones who must mark the site in the preoperative holding area before the patient ever rolls into the OR. And please, listen up, because here is a massive exam trap to watch out for.
The mark must be made with an indelible marker using the surgeon's initials or the word yes. You must never, ever use an X, because an X could very dangerously be interpreted by someone as do not operate on the site.
Section 4. NPO Rules and Latex Allergies, Preventing Aspiration and Fatal Reactions.
So NPO stands for nil per os, which simply means nothing by mouth. Noncompliance with NPO status risks pulmonary aspiration, which is when stomach contents get inhaled into the lungs during anesthesia, and that is a huge emergency. To prevent this, the American Society of Anesthesiologists uses what we call the 2-4-6-8 rule. It's an amazing mnemonic to anchor this in your mind. 2 hours for clear liquids like water or black coffee. 4 hours for breast milk. 6 hours for a light meal, infant formula, or cow's milk. And 8 hours for a heavy, fatty, or fried meal. Now, I need to loudly flag a classic CST exam trap right here. Cow's milk is not a clear liquid. Do not let them trick you on test day. If a patient had a splash of milk in their morning coffee, they instantly fall into that 6-hour fasting category, not the 2-hour clear liquid category.
Next up, allergy documentation. You're going to see NKDA on charts all the time, meaning no known drug allergies. But here is the critical distinction. NKDA does not clear a patient for latex. Why? Because latex isn't a drug. It's a completely separate assessment. A patient can absolutely have NKDA and still have a fatal anaphylactic reaction to a latex catheter or a pair of surgical gloves.
And that brings us to a highly tested exam trap. Spina bifida patients have the absolute highest risk for latex allergies out of any patient population. This is due to their lifelong repeated exposure to latex products. If you've got a spina bifida patient whose latex status is somehow undocumented or unknown, you have to immediately treat the room as latex unsafe. You alert the circulator and initiate a latex safe room protocol while they confirm the status. You definitely don't just wait around and hope for the best.
Section 5, H&P Labs and DNRs. Let's talk critical numbers and laws. Sear this number into your mind. 30. The history and physical, the H&P, must be completed within 30 days before surgery. That is a hard, inflexible rule. Furthermore, if that H&P was completed more than 24 hours before the surgery, an updated assessment has to be documented in the chart on the actual day of surgery. If an H&P is older than 30 days, or it's just missing entirely, the case stops.
Now let's talk about advanced directives, specifically do not resuscitate or DNR orders. A major board vitals trap is thinking DNR orders are just automatically suspended during surgery by some kind of universal law. They are not. While a lot of facilities do have policies that suspend them, it's not a universal guarantee. The crucial point you need for the exam is that any modification to a DNR has to be explicitly discussed with the patient or their proxy and the surgical team, and it absolutely must be legally documented before the case ever begins.
Section 6, Special Patients in Rapid Review. Adjusting the standard playbook. Obviously, not every patient fits the standard playbook. Here are the specific adjustments that frequently pop up on the exam. For pregnant patients, you must ensure a left lateral tilt positioning after 20 weeks to prevent aortocaval compression. For pediatric patients, drug dosing must be meticulously verified because it is entirely weight-based. For bariatric patients, you always verify the OR table's maximum weight capacity and make sure the bariatric accessories are documented. And for immunocompromised patients, strict aseptic technique is absolutely paramount, and their increased infection risk has to be verbally communicated to the entire sterile team.
Okay, let's bring this all home with a rapid-fire review of guaranteed test points. I want your energy high here. Ready? Who gets informed consent? The surgeon. What is the NPO fasting time for cow's milk? 6 hours minimum, because it's not a clear liquid. What patient population has the highest latex allergy risk? Spina bifida patients. And finally, where and when exactly does the timeout happen? Inside the OR, immediately before the first incision with everyone present.
COE Academy students, I want to leave you with this final, crucial thought. If a single document on that chart is wrong or missing or mismatched, are you fully ready to speak up and stop the line to protect your patient? Because mastering this material doesn't just mean you're going to pass the CST exam. It means you are going to be a surgical technologist who literally saves lives in the operating room. Documentation is not paperwork, it's patient safety. Keep studying hard, trust your training, and I'll catch you in the next explainer.